Hello, everybody. It is December, and we are here with the Tough to Treat podcast. I'm Susan Clinton, the co host, and I'm here with Erica Mello. Hi, Erica.
Hi, Susan. How are you?
We wanted to pop in real quick before the podcast, episode number 111 today.
One.
111, and tell everybody that we are finally ready for Christmas, which means that you can treat yourself to an early Christmas present by joining our podcast club. We have the membership ready to go. We have a URL for you. It is toughtotreat.supercast.com. Join us in our membership site. You'll still be getting the regular podcasts that we put out every other week. But in addition to that, you're going to be able to listen into a new podcast that we're going to be doing with interviewing what we call clinical heroes. And it's always not people that, it's not always the prominent people that you hear about out there, but the people who are in the trenches doing regular great work. And we thought we'd bring their stories and some new exciting information from that world into our podcast club. We also have a section that's Ask Me Anything, and you'll have the opportunity to put any of your questions, case stuff in there. And once a month, we're going to be recording a video of which we will be answering some of those questions. So right. Be sure that you take advantage of that opportunity to get in front of us to ask some questions. And, right. We'll have the opportunity to maybe, dial in some experts, and we'd love to hear who you want to hear from as well, so we can interview them. And we're going to have a lot of fun with this. So give yourself an early Christmas present. Join our podcast club. We'd love to have you in there, and we would love to be able to answer your questions more directly.
Yes, and to be in, I think it'd be a great gift for anybody, and even to yourself. And the Ask Us Anything is for our members, and you can type the questions in, and we will answer them on the Ask Us Anything podcast as well. So feel free to do that, and you'll be getting as Susan mentioned, the other episode. There'll be two additional episodes in addition to your regular podcast that you normally would get. It will appear as a premium membership on your podcast feed. It's pretty straightforward. The information's on the website, as Susan mentioned, toughtotreat.supercast.com, and you'll also have access to all of our show notes. We would love to see you there. Thank you.
Yes, and if you have any questions, you can email us at erica@ericamello.com, or my new email, which is the one that's preferred for you to use, is susan@ltiphysio.com. All right, enjoy the podcast. Hello, everybody. I'm Susan Clinton, the co-host of Tough to Treat, and I'm here with Erica Mello. Good morning,
Susan.
Erica.
Good morning, Susan. How are you on this lovely morning?
Great. It is podcast number 111, so 111. Welcome, everybody. And today we are going to talk a little bit about a case that I have of lateral hip pain. And in our email that goes out, so we have referred to a couple of other cases that we talked about it on other podcasts as well. So you can go and have a listen all the way around. We had a listener pop into our inbox and was asking some questions about what we thought about lateral hip pain and especially exercises. One of them that they were bringing into question was the use of clamshells. I don't like the name of exercises, so to speak, because I think that we should be a little bit better than that, but there is jargon out there, and I think everybody knows what a clamshell is: laying on your side with your hips bent at least 45 degrees and doing a hip abduction external rotation with your feet staying stable to strengthen the lateral hip muscles. And we're going to talk a little bit about functional exercise and exercise progression with this, and maybe bring into some questions about what would be some really good things to do and what maybe not be so helpful as we move through this. So I'm going to get right through it.
Sounds good.
So this lady is 45 years old and complaining of pain on the right side of the lateral hip around the trochanteric area. This came on about 8 months before. She was doing some weightlifting. She was doing a lot of pushing and picking up and moving things. If I remember right, she was like, cleaning the yard, leaves and all of that kind of stuff. There was a lot of bending and side movements, bending and lifting, bending and twisting. Noticed kind of like some issues on the side of her hip, didn't think too much about it, thought it would go away. It kind of got a little bit better. It got a little bit worse. It got a little bit better. It got a little bit worse. And now it's just kind of this nagging thing that has turned into kind of an area. She could draw a circle around her trochanter and really kind of pinpoint the area. And where she was really pinpointing was right above the trochanter and behind it. That was like, she could, almost like a comma, she could draw that little semicircle there. And she said, that's the worst of it, but she gets some aching down the thigh, and into the lateral knee. And it's all dependent upon if she does a lot of activity or not. When she doesn't do activity, it's not quite as bad. It's always there. But if she does a bunch of activity, by the next day, she has a bit of a flare up that really involves more of her lateral thigh and, the lateral side of the knee. So she has pain. She can't lie on her right side. It bothers her. If she lays on her left side and her leg flops over into abduction, it bothers her after time. It doesn't bother her initially, but if she wakes up like that, she has to move, and it's really difficult to move her leg. It just feels bad. If she crosses her leg over in sitting, so she crosses right over left, and that's her preferred way of sitting. So she's always battling that. And then, so those are the main things. I asked her about, what about going upstairs? What about squatting down? Those types of things. And really, generally, that's okay. She doesn't notice it. These are when she really notices it. It's when she's sitting, she crosses her leg over for a bit. When she's, she can't lay on her side. And she does notice it a bit with driving.
So going upstairs didn't bother her at all?
Not really. I mean, it's not like when she pushes on it.
Yeah.
So she has much more issue with it being either kind of in an elongated position, or if it's got compression.
Got it.
That's where she really notices it. And then driving, if she's driving for long periods of time, it can start to bother her. And that makes a lot of sense, because then you've got, the foot, it's the right leg, and that's your gas pedal brake leg, and probably moving across back and forth to the, brake, or maybe even if you're just, sitting and your leg is rolling out, there might be some compression of the soft tissues there. Those are that, basically, and this has been going on, like I said, 8 or 9 months. And it's kind of at this standstill. It hasn't really gotten better. It hasn't gotten worse. But the soft tissue piece is really painful. And these are the things that are bugging it. And activity, lots of activity, makes it worse by the next day. She may not notice it right after, but generally by the next day, she really notices it.
And does that mean walking, biking, or just anything?
She likes to bike. That seems to be somewhat better than walking if she goes for long walks. She also has trouble with just doing general gardening and cleaning up and moving around the house. If she's like cleaning her house all day,
just general activity.
She'll really pay for it. So it sounds like a lot of different kind of movements. And it also, because the pain doesn't really, the issue gets worse the next day. It almost sounds like this is kind of, it definitely is chronic. It's been around for 8 or 9 months, but it also sounds like it has a bit of a neuroimmune response. Because, when we don't have immediate stuff during the activity, or even just right after the activity, we have a delay that, that can really pinpoint towards kind of a neuroimmune response, which means, that the nervous system is definitely involved in kind of an overprotective kind of immunity type thing that goes on. I did mention that she is about 45 years old. So I asked a number of questions, as I usually do, because this is a prime time for, the perimenopausal era to begin. What are her periods like? What's happening around all of that? How is her sleep? Any other joint aches and pains? Any other noticeable areas where she's having, some of this general type of stuff too, like her shoulders, her knees, her feet, her back. Anything that's happened in any other joints have been kind of transient. She did say that her left shoulder sometimes feels pinchy and, will get sore if she overdoes, too much with it, but it hasn't been anything that's lasted and it doesn't bother her when she lays on it. But she did mention her left shoulder just a little bit. Her periods have changed. She has cycles to where she has very heavy bleeding. And then she has cycles to where it's almost non-existent. And she realizes that she's probably kind of moving through that time. No real huge hot flashes, but sometimes she's noticing that she's hot at nighttime and sometimes gets a little sweaty at nighttime. And that's, and it was interesting because as we were talking, she goes, I always thought it was my hip that was waking me up, but it may be that, this issue is waking me and I'm noticing my hip,
Yes,
so,
exactly.
So it's all part of the same, physiology and things like that. And, she's not having a lot of trouble falling asleep. So, that hasn't quite started yet, or it may not, just depending upon her levels and how she's doing. But I thought it was important to kind of just note that because I want to just remind everybody that this is that perimenopausal time or that transitional time can be a time where we can have some changes in the tendons.
Yes.
And I know everybody is kind of like, let's get everybody on, some HRT to support. But remember, HRT helps the muscle and helps the bone, doesn't help or change the tendon.
Yeah.
So you can end up with, and she's somebody who has, pretty good strength. And it could be just that for whatever reason, that particular tendon became a bit vulnerable. That's just my hypothesis going in, let's test it and see what we find. But I think it's kind of pretty important to think along those lines because everybody either wants to say bursitis, give them anti-inflammatories. But if you've got a tendinopathy, we really don't want to hit them with a lot of anti-inflammatories because we want to figure out how to support the tendon as best as possible through this time. So, but let's see what we find out. So I do my usual thing. I had her do some bend overs. That wasn't really problematic at all. She was able to, with a wide stance, squat down all the way with kind of a, not feet together, but, just a normal feet under her shoulders. She was able to squat down below 90. She wasn't able to drop all the way. There was, she would have to lift up her heels to do it from that position. Not anything real alarming at all. I did ask her about, when she was like picking things up and gathering things. Like I said, show me what you do when you're like in the garden. And so what she tended to do was she tended to squat onto her left knee and, onto her toes, and her left knee all the way bent and her right leg out. So she would have her foot down, on the right side, and she would tend to stay over onto the left and do her kind of gathering and moving that way. And so I just asked her, I said, can you do it the other way? And she was able to do it. And she kind of was like, I don't know. I never do it. I just always go this way. So she could squat on the right side, with her toe up, with her heel up and have her left foot planted. But she just said, it's never something I do. I just always go the other way.
So both of her feet she's in a squat, but her she's weight bearing on the left and the right full knee is bent, but the heel is on the ground.
Yeah. So it's just kind of like, the right foot is planted.
Yes.
And she's kind of moving around the left bent knee, on the toes, to kind of like, to gather things up and stuff like that.
Yeah.
And she could do it the other way. She just said, I don't think about it. And at the time it didn't make, when she does these single movements like this, it didn't really make her hurt. It didn't change her symptoms at all, like make them worse or anything like that.
Yeah. Did she have any past other injuries, Susan, just before you go on? Any other past movement history?
I asked her about that and she said, and that's great that you asked that. She said, no, nothing that stood out other than, like when I was running, when I was in my 20s, maybe I had, some back issues or some hamstring issues, but nothing, both sides, nothing really remarkable that stood out to her in any way, no accidents or injuries that she could really remark on. no ankle sprains, other than, she said, I'm sure I probably had one or two somewhere,
Right.
but nothing that really nothing that really stood out in her mind, along those lines. Just to also say, she has 2 kids, and they were later in life children. So one is 3 and the other one is 1. So she kind of in that postpartum era too. And I probably should have mentioned that. So we've got the hormone transition from, pregnancy to postpartum with a 1-year-old and a recent, 3-year-old, plus perhaps moving into that perimenopausal time. So there could be some of that issue as well. So anyway, so we decided to take a look at, doing some other different things. So I got her on her hands and knees because I wanted to see what she looked like when, because I was watching her squat. She looked like she could be pretty even, but it looked like that left side came down more. And part of that is her movement pattern. She's just used to squatting onto her left side, because that's how she's always done it. It's how she grabs her kids. That's what she just kind of moves that way. And I thought, let's see if we can change this up a little bit, change the context. So I got her on hands and knees, and I just asked her to, sit back onto her heels, and I stood behind her and watched this happen. And sure enough, that left hip really led the way. She really folded more on the left side and came back on the left side. And, there was kind of almost a concomitant twist in the trunk, the thorax a little bit. So the left trunk rotated to the right. So the left trunk came up as the hip came down faster, kind of like she was almost pushing herself back that way. It was very interesting. And her head stayed up, so I asked her to drop her head to where it was, parallel with her spine, and do it again. And as she came back, her head came up again. So it was like, okay, let's just play with this. Rather than trying to correct her hip, I decided, let's go to the other side of the table. So I just got on her ears, and I just kind of put her head in that nice little neutral position. And I said, I'm just going to hang here with you. Let's just go ahead. And from her head, I could really feel her trunk twisting. So it was very interesting, because I thought, okay, I just want to see, but because I'm thinking, like, right off the bat, I'm thinking, oh, there must be a dural restriction in there,
right?
But it really wasn't. It was much more that this twist was how you could just feel it, all the way up through her head. So I just helped her kind of keep her head stable, and as she went back, she was able to do it, but she wasn't able to go as far.
So when she went back onto all fours, she really shifted that whole trunk to the left.
Yeah. And that thorax twisted up, actually. The left side twisted up towards the ceiling. Just a bit, just a bit. Very interesting, and I could feel it through her head. I thought it was, so it wasn't, the neck and the head was, it's like the pull was coming from in there. So then I went back around and told her, I said, just, if you can keep your head in that position, that she's, a quick learner. A lot of our clients can figure it out once we help them and give them a couple of cues. And I just went back to her pelvis to just, kind of see if we could, guide that right side to come down with the left side and not have the left side lead the way. That if it was just a stubborn movement system, kind of pattern, or if there was really a reason why she was doing that. And from her pelvis, and just guiding her evenly down, it really was a struggle for her because she couldn't lift her thorax up.
Interesting.
Yeah. So I started kind of thinking, okay, what is it? Is it thoracolumbar area? Is it really a thorax driver? Is it a scapular driver? That thoracic scapular kind of thing. There's something in this area. But anyway, what I confirmed with her is I said, okay, just let your trunk do whatever it wants to do. Let's see if we can just get both hips down, because I wanted to be sure that she could fold well on the right. She was folding well on the left. I know she could in standing, but I thought in context, let's see if she can. And she could. So, she could get all the way there. It was, she just preferred to have that trunk kind of just shifted up as she did it. So then I asked her, where do you show me how you carry your kids.
Yeah, exactly.
And sure enough, on the left side.
Yeah, of course. Of course. Exactly. And with her hands, obviously that's the trunk control, right?
Yeah, exactly. 100%. And so, just kind of looking at that and thinking about that, I said, okay, let's lay on your back. And let's just see what happens when let's bend one hip, in the plane of motion, so I just wanted to see flexion.
Yeah.
And see what she was doing. And, she could do it on the left, but she really liked to do flexion and kind of external rotation
On the
on the
right.
left side, on the
On the
left
left.
side. Mhm.
I got it.
And that makes sense because that's where she would be like moving to right. On the right, she could
Yeah.
really control it better.
Yeah.
She could control that, flexion extension plane a little bit better. She didn't really have a lack of range of motion as far as flexion went on either side, but she did have a noticeable lack of internal rotation on the right side.
Okay.
So external rotation was fine in 90 degrees of flexion and in 0 degrees of, flexion, like with the hip straight. But when we looked at internal rotation, she was definitely did not have as much. Her whole, she lifted her whole hip up on the right to like internally rotate. So I flipped her over on her tummy to try it with her hips straight.
Yeah.
Mm-hmm. And definitely still a lack of internal
limited.
Rotation. Yeah.
Wow. Okay.
So which I thought was kind of interesting as well.
Yeah.
So, so whatever was happening with her hip external rotators didn't really like for her to go into hip internal rotation. So it kind of made me start thinking, all right, we've got something going on in the thorax around the scapular area, perhaps thinking about holding the kids and some of the stuff that she does and that movement pattern. But this hip over here too, there's an over recruitment of those hip lateral rotators. So I asked some other questions at that point because I started, especially with the legs straight and going into hip external and internal rotation, I started thinking about obturator internus as well, because that is a rotator of the hip with the hip and extension.
What was the end feel like? Was it muscular or was
it wasn't so much that it was a hard end feel. It's just that as you got her to like maybe about 5 to 10 degrees of internal rotation, she raised the whole hip up. She's in prone, and as she goes into internal rotation, the opposite hip starts to come up. So she's, so she rotates her pelvis to get the internal rotation rather than it happening at the hip.
Yeah, I was going to say, I'm thinking maybe in the thorax too.
Yeah, exactly. And there it is. And so that's like, why does that whole side like rotate up? Because it does that because she doesn't like to go into internal rotation. So she's doing the rotation above because it's not happening at the hip, which is, I find, very, very, very interesting. And I bring this up for a reason, because if we've got maybe a little bit of tendon, issues, who knows? And if we have over recruiting, lateral hip rotators, the last thing I'm going to do is have her do hip rotate, is have her exercise with, with the hip rotators. I want those babies to calm down. I want to get some coordination in there and not over recruit an over recruiting muscle group.
Yeah, exactly.
So this is, I bring this up because the listener had asked, specifically about clamshells. And, this is something that I've seen people do a lot, is put people on the opposite side and just have them start exercising. That movement hurts. That's not comfortable for her. And she does, she does have the range of motion to go into that external rotation. What she doesn't have is she doesn't have the motion to go internal. She needs the opposite.
Exactly.
Because she's doing it at the trunk, we have to figure out how to stabilize the trunk and allow that hip to start exploring and beginning to to stop over recruiting, in those lateral rotators, so that she can get some rotation below so she doesn't have to do it above.
Right, exactly. And I mean, I think just because people have hip pain, doesn't mean they need clamshells, doesn't mean they need strengthening, but I like the all fours position because that's another great way to assess it, in a different context. And so when you held her thorax, sort of prevented her from rotating, she couldn't get down as far, you said, right?
Right. It really limited her. She had the fold to do it. She has the flexion to do it, but she just was, her system just couldn't figure it out. And I think it was because those external rotators are overfiring, and we're putting her in a position where they're trying to link them. By, going into full, that whole, child's posy type thing, and so that lengthens, through the pelvic floor, you have to, and she just, because she couldn't do it, the trunk was like rotating to allow her to fold down more.
Fall down.
But she has the flexion to do it, is what I'm saying. But when you put it together with knee flexion, hip flexion, trunk, that whole motion together, that's where you would see the issue show up. Like a single joint wise, the only thing she was lacking was internal rotation. But when she was like trying to move through the whole body part, then she was really lacking. She had to have some concomitant rotation at the trunk to allow her to fold well in that full body type of motion.
Yeah, and if you think about gardening and moving, is rotation, right? That's triplanar, and that makes sense as to why, she could compensate through the thorax and through the other hip, but then the next day she'd be pushing up against that barrier every time.
Yeah, all the time. Pushing, and they over recruiting, and maybe a little tendinopathy kind of thing happening physiologically, all of it setting up for that nice, kind of neuro response that, that isn't going to work. And again, when we think about that with any other group, especially like the Achilles, one of the things that the Achilles doesn't like, if we're running into trouble there, is it doesn't like lengthening, but it also doesn't like shortening. But lengthening is hard, so, and because walking is lengthening, that's why walking over time really feels terrible on that, when you do it. And so being able to gain that eccentric control, or that eccentric, lengthening is important. And that's what she was lacking in her hip.
Yeah. And that's why stairs were fine.
Yeah.
Because she already had the strength.
Yeah, because she could do it, but of course she's not going up and down 100 steps a day either.
No,
and maybe if she did, that would bother her, because it seemed like, a lot of activity, bothers her.
Yeah.
And causes that to happen. She is no longer breastfeeding. She weaned her youngest child off at 8 months. And mainly, she said it was kind of a mutual consent on both their parts. He wasn't interested in, and her supply was not as bountiful as she had hoped. And so that she said, it was okay. It wasn't like she felt like she had to do it because of work or anything else. It just ended peacefully. But I, just asked her some questions about, when you're sitting and feeding, like, what are you doing? She likes to sit with her right leg bent underneath her. Like, makes sense, right?
Oh my Lord.
Because it's just comfortable, and she can hold, and so she can twist her trunk the other way and hold her baby, and use her right hand. And so we've got a lot of things that are going on here that are feeding into the motor plan. And and you always talk about this, they can adapt until they can't.
Yeah.
And so she adapted to these two young children and to her body changing and all of this. And the failure point, or the
buckle point.
Yeah, the buckle point looks like it's that she's just developed this concomitant over recruiting of the hip. So as I'm getting back to the obturator internist, I asked some questions about urgency, frequency, incontinence, anything else that might be going on. She did say that she does have some urgency frequency. She says it's weird, she will be fine, and then one day she'll feel like she has to go to the bathroom a lot, and then she'll be fine for a few days. And so I asked her point blank, I said, do you notice the urgency frequency more when you're like after when you have higher symptoms, like down your leg and all that, aching and all that stuff? She really couldn't answer that, so I sent her a way to figure that out. I'm just curious, just kind of track it. Like, when you have urgency frequency, let me know what's, kind of how what else is happening over this next week before you come back in. So what I did with her was very, very, very simple. I just wanted to do, basically, I told her, I said, can we figure out a way for you to sit and feed your baby without tucking your hip under? Just let's do a little bit of changing. When you squat down, can you make an effort to just start to shift over a little bit? When you're laying in bed, let's definitely put a pillow between your knees. It's more comfortable. Just go ahead and do it. And then I just gave her the simplest exercise, because I know that she wasn't going to lay on her stomach and do it, I just said, let's just start where she is, right? She's feeding her kid, she's sitting. I said, when you're sitting, can you just sit in can you just put both feet on the floor, or, have both legs even, so that you're not tucked up underneath, with your knee out to the side. And while you're there doing it, can you just go into a little, can you just bring your foot up to the side a little bit, a little internal rotation, basically,
Mm-hmm.
just a little bit,
Yeah.
just a little bit. I want you to
Yes.
just kind of just get a little movement in there, nice and easy. Don't push it. Don't do it to where it knocks you over. If you have to lean over to the left to lift your foot up, then don't do it. Just stay real easy. We just talked about just kind of doing a nice little swing with the foot to
So
just
in
kind of,
open chain or enclosed
yeah,
chain?
an open
Open
chain.
chain. Got it.
Yeah.
Got it.
Just thinking about how can
Ah,
we start to, first of all, get her out of that kind of sitting over on her left hip.
yes.
And at the same time, let's just start thinking about working those, using a little bit of internal rotation to kind of start to decrease the external rotation over recruitment,
Mm,
but just go easy
yes.
with it. Not enough
Yep.
to like get everything all cranked up and excited and hyper excited. And so
Mhm.
that's what I sent her home with. And I just, as we're talking here, do you have any thoughts or questions that are coming up?
So I know people are going to ask, you mentioned obturator and turnus. Would you give
Mhm.
her a self-release or something like that to do as well?
Not yet, because again, when we start to meet people where they are, here's somebody who's a mother of two young children
Right.
and having this issue, and she's very busy, and the biggest problem she has is overactivity increases her symptoms. And what I was doing was just trying to break down the movement pattern and find out what was happening there. And it's kind of almost like the story of two drivers. We have over recruiting of hip, rotators, but we also have this concomitant rotation of the trunk. So I don't know which came first. So I thought we're just going to do both.
Right. And we always talk about what's the impairment. And so the
Yeah.
primary impairment first was probably the overactivity.
Yeah.
And, and because of that, you had this motor pattern
Mhm.
that, served her for a certain period of
Oh
time. So,
yeah,
you know,
100%. I mean, she has a 3-year-old, so she was used to, carrying the child on that side and
right,
doing those
right.
things, and just
Yeah.
all of that is in there together. So what I wanted to do is I wanted to start working on the rotational piece a little bit, to kind of just stop the over recruiting, or to start to change that over recruiting, but also bring the awareness in that she's always over on that left side.
Yeah. Yeah.
And what
Yeah.
can we do to kind of start bringing her out of that movement pattern just a little bit,
Yeah.
and bringing that up into her awareness? Like when you squat, can you kind of just move to the right a little bit? When you do this, can you just make sure you're not, falling over onto the left side? When you sit in to feed your child, can you sit in a different position for a bit? Can you
Right.
stop crossing your legs right over left?
Yeah.
Can we,
Right.
yeah, those kind of things. Mm-hmm.
Ingrain it into her day, because a lot of
Yeah.
times, like I had a patient the other day who said, oh gosh, I've been sitting like this forever, like he had
Mm-hmm.
horrible back issues. I'm like, well, sometimes it's what they're doing that's making them worse, right? And so in this
Mm-hmm.
case, you want to sort of get her out of that movement pattern, and then you could go on and maybe do like on all fours, or you can progress, but you want to make them aware of what they're doing first, because you can give them an exercise program, but if they go back to that same motor pattern when outside of your office, they're just going to feed into their problem. So I
Mm-hmm.
find that, and I agree, the first couple of sessions are really educating them on what not to do. I mean, I don't use the word not in air quotes, you know what I
Right,
mean?
right. Exactly.
Yeah. Yeah.
Exactly. So, so to make kind of just make this trail along here, she came back the following week, uh, a little bit better. Was very noticeable about the things we talked about. So she said, I was super aware of how much I really do lean over to the left, and even driving. And, so I started to try to change and straighten it up a little bit. She goes, it's really hard because I'm, she just was very aware of what she was doing. She did
Yeah.
say that she had a day where she had, where her symptoms were worse and her urgency frequency was worse at that point too. So we
Mm,
talked a little bit about, kind of the musculature and how that particular hip rotator is on the inside of the pelvis. Like it's a big, its muscle belly is inside the pelvis, not on the back side of the pelvis. And it, pulls on the fascia around the urethra. And, so when it's over recruiting,
right.
it can, produce some of those, be part of the symptoms. So we
Right.
talked a little bit about, urgency frequency and triggers for that. That, caffeine can be a trigger, not drinking enough water could be a trigger, drinking too much water can be a trigger, so we went through, basic pelvic health stuff around that. But the biggest thing was getting, the musculature to stop over recruiting. So,
yeah.
And didn't see any reason to like do an internal exam. She wasn't having any problems with incontinence. I already know those muscles are over recruiting. So if I had done an internal exam, I'm sure that on the right side of her pelvic floor up into the obturator internus, it would have been, it would have been over recruiting. So, it would have probably been tender, but no pain with sex, no other indications that there was anything seriously wrong there. So just, a matter of the hip rotators just really being on, and maybe in an effort to protect the tendon a bit, maybe not. So I sent her to a physician because I wanted to know what shape the tendon was in. And there's a physical medicine doc that I use that I worked with a lot, and he did a ultrasound. I wanted him to take a look at her hip rotators and see what you think. And he said that he felt like that there was a small area of degeneration. And he said it was at the top of the rotators, which would have been the level of the obturator internus as it goes into to hook into the right underneath the trochanter on the top superior side is kind of where that tendon tends to go into. But he said it wasn't anything, terribly alarming, but he goes, it can be symptomatic. He offered to inject her. She decided she didn't want to do the injection. She felt like it would be temporary, and he told her it probably would be. And that the best thing for her to do was to continue with the therapy. But he also warned her off of doing things like clamshells too, which was interesting. But I know this guy really well. Yeah. He said, don't do those. Like, and the other thing, is this would be somebody that if they were going to a gym, I would ask them not to do the seated hip abduction exercise, that I see a lot of women doing. And, it's just like, it's not going to be helpful. I said, these muscles are strong. What they're not is they're not able to like, tone it down and coordinate with the other muscle group. And that's what we want a balance of that. So we're going to work the opposite. We're going to actually start working more into internal rotation.
Yeah. Was there a noticeable difference, Susan, in supine with the hip flexed and prone with the hip extended in the range, or was it just stiff equally?
It was pretty equal.
Okay.
Yeah.
Okay.
So it was all the hip rotators, so it wasn't just the one. And that would make sense because they're all going to pretty much fire up and work together. A lot of them, as we kind of move. So what did I do? So we already know that we were working on the seated internal rotation with the foot and open chain. She was getting better at that, which was good. Keeping her thigh still so it's rolling and not moving into ab and adduction as she does the exercise.
Yep.
But it was time to kind of start, getting things going here. And so I went back to the wall and put her fingertips and hands on the wall to stop the rotation of the trunk. And we started doing just the simplest things, which was, can you stand on one foot? And she could stand on her left foot just fine, but she really noticed that, I said, she really shifted off to the left.
Yeah.
And it's like, this is the stable side,
right? Shifted to the left. Yeah.
And it was like, okay, you're in a cylinder, do not touch the side of the cylinder. And she really, really, really struggled with that. So all we did was just lift the heel up on the right.
Yep.
So she could get the feel of starting to unweight and starting to get control. When she stood on the right, she really wanted to go into external rotation at the hip. And again, that trunk wanted to shift left. So it really helped her kind of begin to figure out, like how to really be able to stand on one foot and not do that shifting. And that required the lateral hip rotators to not over recruit so much, because the wall was taking care, helping, not completely controlling it, but helping take care of that rotation that she really wanted to do up into the trunk and the left scapular area.
Yeah. And you take away the compensation with the wall a little bit because you get the tactile feedback, which is great.
Yeah, which is great. So then we switched around and I thought, let's do it a little bit different here. Let's put your back on the wall. and just see if you can stand and do like, lift your knees up, kind of like a march. And I just told her, I said, feel your back on the wall, feel all the points that it's touching, and don't let that change. And literally she had to put both hands against the wall too, and her palms against the wall in order to lift her left leg up and her right leg up.
Wow.
And but that gave her the sense though that that she needed, and she eventually was able to do it without her arms plastered on the wall too, and she could really feel that she was pushing that left thorax into the wall. So she was able to start changing that right away, and those were two great exercises for her to do, because she could do that on the countertop. I put in her hands on the counter, she could put her hands on the wall, and then I gave her the doorknob squat, because remember, she likes to go to the left, so she could use the door as midline. And she could just kind of feel her. So I said, just every once in a while, grab the doorknob and squat down, just to kind of make sure you're kind of saying, almost like a reset exercise in a way,
exactly.
because she liked it. Yeah, it felt good, but it also, it gave her that sense of, midline, and she was lacking a little bit of. And then while we were working on the as we kind of progressed forward, I started bringing in, because this trunk was kind of the issue. She carries her kids there, feeds her child there, all of that. And I thought, we got to figure out another way to bust this up. So one of the things that I did, which was really kind of interesting, as she was getting to where she could stand on one leg and she could lift her leg up, and that was happening. And, she could do some partial squats on the wall, and those types of things. I started having her turn her head left to right while she was doing it, and looking left to right, and really kind of beginning, especially to the right.
Yes.
Because the left was easy, and just I wanted to just do something neurologically to start driving some new movement patterns in there. And at first her balance was all over the place when she did it, but we got her to where she could do the, standing on one leg and doing the whole clock on the floor thing, and moving her eyes and her head around. And the clock stuff was nice, because she had to get that sense of not over rotating in the trunk, but then she got to where she could reach her right leg out in these directions, but she could also stand on that right leg and let that left leg go, which was bringing that rotation in closed chain for her in a real functional way.
Yeah, exactly.
And we did some stuff with grabbing the TheraBand and wrapping it around a pole and holding the TheraBand in front of you and doing, full body rotations, both directions, eyes and head and stuff, so that she would have to rotate through the hips and through the foot and all of those, to bring that all into full body things to change this up. It took about, I saw her over a period of about 3 months. I didn't see her every week. She'd take the exercises and she would go. What she was doing for her, what we were doing for the soft tissue piece, because there was a real soft tissue piece, that didn't feel good if she was, compressed on it, or, whatever was happening with that. Is I taught her how to, take a nice, soft, flexible Franklin ball, the green one with all the little texture on it. And I took the air out, so it wasn't very fat, it wasn't hard. And I just taught her how to do some nice skin rolling, with that all around the thigh, up and down, again, the idea of, just connective tissue mobilization, to really get to those, peripheral cutaneous nerves, to calm that neuroimmune response down a little bit, and to get used to touch and to bring blood flow to the area. And it felt good, and she liked it because it felt like we were addressing the area as
meaningful.
well. And she was doing all of, it was meaningful to her, but, she was doing all the movement things that she needed to do, but we still needed to calm that area down too. And so we did, that kind of stuff. Once she got better, with that, I had her just put it up underneath her trochanter and start to sit on it some, and, do some self-massaging that way, so that she could get used to compressing the tissue. And then we gradually exposed her to laying onto her right side. She needed to develop the ability to, have compression in those tissues, and not be afraid of laying on her right side anymore. And it took time, and it took some finagling around. And it's just 1 minute, whatever you can. I don't want this to make you hurt, but I want you to get used to, being able to feel that, to be comfortable there. And so that took longer, for her
Yes,
to
that's hard
get,
to,
but that,
yeah,
so it did, but she eventually got, 6 months later, she got the ability where she could sleep, for an
yeah,
hour or two on her right side, which was a
yeah.
huge victory for her.
Yeah, that's hard to do. I've had hip pain, and
Hmm.
that
Yeah.
lying on that side is the last thing that gets
It's,
better, at
yeah,
least from
yeah.
my experience.
Hmm.
Yeah.
So, and the name of the game with her was to find another way into the system to get internal rotation,
Yep.
decrease the over recruitment of the hips, of the hip rotators, and not increase already over recruiting hip musculature by doing leg lifts, abduction,
Yes.
abduction, external rotation, any of
Rotation.
those types of things. She was already there all the time. She needed to be the other way, but to build it in a way that was very functional, because, here we have our clients that are, they've had this for a long time. It's not going to go away in a day. An injection might have helped a little bit, but probably not. I've seen these injections not help. This particular doctor was savvy enough to realize he wasn't going to inject anywhere around the tendon. He was just going to go after the muscle belly,
Yep.
and see if he could get it to just stop over recruiting and calm down. But, like he said, it's, he felt like it might have been just a temporary fix, but if somebody's in, just a ton of pain, maybe that was a way to go, just to shut
Yep.
it down
Yep.
and have it happen. But, the idea here was to just really get her to start recruiting, differently, and not go into that over recruitment response on the right side that she was having.
Yep.
And so it takes time though for that to happen, and that's why I put the whole neurological system in there and started doing the right and left, and did the clock yourself, and
Yes. You have
made the
to do
clock
both sides.
small until she could get better at it, and then we made it bigger, and it was something that she could do quick, she could do it fast, she could pop these things in during her busy day. As she was feeding her kid, I would remind her about her, doing like little foot swings, and maybe even shifting her weight to where she was sitting more on the right side, or she was like turning her head to some other sides.
Yeah, and I
Just to
think
kind of bring that right left rotation piece back into her system, so that she could bust up some of that trunk rotation that was like so ingrained in that movement pattern for her,
yeah, yeah,
to start changing that up a bit. Mm-hmm.
yeah. No, I think that the main issue that I think that listeners need to take away is, as well, is that, what's the primary impairment? And, once you have that, you're overactive based on your physical exam, overactive system, right? Overactive external rotators. And how do you take that out? Your imagination is, eventually you're going to do a ton of rotation. That's hard for a hip to do initially, but you want to make them aware of what what you're trying to achieve, right? And so good. And then, because she's she's 2 kids, you want to incorporate it into her day. And I think that's because you can, once you know what the impairments are, what are you trying to do here? Use your imagination, be creative. You can do like you did. You can do trunk rotation, clocks, app, whatever's in your clinic. But the key is, why are you doing it?
Yeah. To
And
what end
that's
are
the
you?
issue.
Yeah.
Exactly.
And why are you selecting the exercises you're selecting?
Exactly.
So that
Oh,
there
because the
has
hip is weak. The hip is not weak,
no, the hip
right?
isn't weak. The hip has movement pattern issues. So
Right.
that's how can we change those movement pattern issues?
Right.
And what else can we do to help her calm down that neuroimmune response?
Yes,
Because
exactly.
we know it takes tendinopathies a while to recover, so we want to do the things that we can do so that tendon's not always being, pulled on and worked on, or having
Mm-hmm.
to come into play as much, but also to remember that, we need to support the rest of the system too, and the soft tissue system. And,
Mm-hmm.
some people might have done cupping, some people might have done, other things. I'm a big person on, kind of skin rolling and connective tissue mobilization, mainly
Yeah, I
because of
like
that
that.
whole, it's just such a great way to get into the nervous system through the cutaneous nerves and begin to change some things up and
Yeah,
change
and
the response of the system. Mm-hmm.
yeah, and Susan, the green balls you're talking about are the ones with the
Mm-hmm.
little spikies at the end of them you're
No, they
talking
don't have
about?
any spikies there.
What are they?
They're just textured. So they
Ah,
have like
got it.
little indentations all around them, like little
Ah,
cups on them.
oh, okay.
Yeah, yeah.
I'm
If
familiar
you
with the orange Franklin balls, but not
Yeah,
the green
yeah,
ones.
yeah. So if you go to OPTP or Amazon and type in Franklin
Yeah.
balls, you'll see the green ones.
Okay, because I have the orange
Yeah,
ones, but
yeah. The orange ones work just as well. A
they're
tennis
very
ball would
smooth
probably
though.
do it. Yeah,
Ah, Got it.
But I don't like tennis balls, especially on soft tissue tenderness, because they're too hard.
Yeah,
I
agreed.
don't want that. I wanted her, like I said, I took the air out. So
Yes,
it was
yes,
kind of
yes.
soft and squishy.
Yeah, yeah, I
If
like that.
you're working in home health, you might want to just, put a rubber band around a washcloth and let them use that. I mean, there's so much you can do. It's just, that's because what I chose to do doesn't mean that, I
Exactly.
just wanted to, my entire reason for doing that was to address the nervous system through the cutaneous nerves,
Got
and
it.
begin to help her have something meaningful to do that felt good to her, and that would also expose her to soft tissue compression
Yeah.
and to, again, through the autonomics, going after a little bit of that neuroimmune response that she was having.
Yeah, yeah. And and it addressed her meaningful area,
Mm-hmm.
even that was her symptom. But people, they actually most people want to feel felt and that you've addressed their meaningful area, even though
Mm-hmm.
that's not their primary like impairment, so to speak. But I like
Exactly.
that. Yeah.
Exactly. Yep.
Awesome.
Okay.
This was a
We
good
look,
one. Thank you, Susan.
yeah, you're welcome. We look forward to everybody's responses. Don't forget about our podcast club membership. The URL is toughtotreat.supercast.com. Join us for all of our new exciting adventures in 2022 as we launch this membership and we began to explore the interviews we're going to be doing, the Ask Me Anythings, and another live question and answer where Erica and I will be answering questions live, and even moving into maybe having some hot seats as we move into 2022 so people can come on and actually have a conversation with us.
Yes.
Only through the membership though, so you got to sign up.
I'm
Tough
looking
to
forward to
treat.
seeing you there.
Yep, toughtotreat.supercast.com. See you there.
Bye, everybody. Happy holidays.
Yeah, happy holidays.